Hey, my name's Danny Tarkeshian. Welcome to the NACDL show 2015. We're currently at the Bellagio in Las Vegas. It's been a great show so far. We've had some great conversations, a lot of really interesting topics revolving around criminal defense, specifically for drugs and alcohol, have just been spurring all around. And today, who I'm actually sitting with right now is Dr. James T. O'Donnell. He's a professor of pharmacology at Rush University. And I would explain his whole career, but it would probably take me about 5 minutes to talk about everything he's done. So I figured, let's hear it from the doctor's mouth. Could you tell us a little bit more about yourself, Doc?
Sure. I'm a board-certified clinical pharmacologist. I am an associate professor and teach in the medical school at Rush. I've been at Rush for almost 40 years. My private practice, I do forensic and litigation consulting in civil and criminal matters, and lately I've been doing more and more on the criminal side with alcohol and drug-impaired driving, and that was one of the impetus to come here. I did work in hospitals as a clinical pharmacist and clinical pharmacologist for 20 years before I launched my academic and consulting activities.
Interesting. And you know, it's funny that we're talking about this because one of the big things I've been hearing that was one of the most attended events was the drug recognition expert seminar that they had yesterday, I believe it was, and that's
Right.
really his wheelhouse and what he focuses on. I'm curious, what are some of the issues in a law enforcement official that's a drug recognition expert in their process? Could you tell me a little bit more about that?
Sure. Well, I was frankly I was surprised when I first heard about this. They call it the DRE, and I think that the fact that they call it a drug recognition expert is an oxymoron because of the limited training. And I've attended a seminar this morning by a former police officer who was a DRE instructor, and he said that this was the highest level of a DOI officer's training, and they spend 7 days in class learning about drugs, and then they go out and do simulations and evaluations, and they're awarded a certification as a DRE after experience in the field of doing 12 evaluations. I was once asked in court what I thought about the DRE training process and how significant it was, and in fact I was challenged as to what gave me the ability to evaluate the effects of drugs as a professional and as a consultant in court. And I said instead of 7 days that the officer's training was, I spent 7 years. I have 40 years experience. I write books and articles about this, and I teach doctors how drugs work. So I describe the DRE level of training as the kindergarten level of pharmacology, and frankly, so I'm usually not that strong in my opinions, but I'm very strong on that. I think that there's an overreach by officers who think now that they're certified that they have the ability to make an assessment that healthcare professionals spend literally years gaining academic training and clinical experience and then do in their daily practice.
It's interesting that you brought that up because just thinking about the attention that a student has to have going through med school is probably one day of med school and studying is probably like the whole 7 day training program that you would go through to become certified.
That's a good analogy. Good analogy. It's almost funny, but because of the impact that a drug impairment conviction can have on a citizen, it's scary.
It sounds like there's a lot of disposition, and I'm guessing that there's a lot of very challenging cases to evaluate from the courts, doctors, to officers. Kind of talking about that and how a lot of prescription drugs, which is your specialty, they're mainly monitored by physicians.
Well, yes, indeed. By definition, only a physician or now a physician's assistant or advanced practice nurse is authorized to um, prescribe a drug, and part of that is an evaluation for the suitability of that drug, and it is continued only after that prescriber monitors the effect of the patient. And they're looking, part of their monitoring is to look for impairments. And many patients, there are literally 50 or 100 million drivers who are taking prescription drugs. And a snippet of an officer going through a rote evaluation of clinical monitoring, that they don't understand the physiological processes associated with it, and making a judgment that someone is impaired as a result of a central nervous system depressant or a stimulant or a tranquilizer or an epileptic drug is ignores the fact that most patients who are taking these drugs take them for months or years, and they get used to the effects. And the real scary part is that the officers in the training, and when they do have a question while they're doing the evaluation and considering their um, opinions, is you can look up 1,000 prescription drugs and find potential uh, words that are associated with impairment, like drowsiness or dizziness or lightheadedness. It doesn't mean that it happens in every person. And so I have consulted in cases where patients were taking pain medicine for 10 years and seeing their doctors regularly, and they're involved in some type of intervention with the police, either being stopped for a headlight that's out or crossing a line, or in a more serious circumstance where there's a accident with injuries, the officer comes in and based on their literally a physical examination based on a week of training, comes up with the finding that the person is impaired by these prescription drugs, and now they're facing a trial with serious consequences if if their lawyer is not successful defending them at trial. It totally ignores the fact that when doctors prescribe and when pharmacists dispense drugs, they and we are evaluating for impairment, and if people appear to be impaired, the doctor's going to stop the drug or adjust it, and the pharmacist will talk to the patient and perhaps call the doctor. We have that training. We have those licensures. The officers do not. So I think it's a real stretch for anybody to say that an officer is capable of making an assessment that a certain drug group is impairing a person.
Absolutely, and that got me really thinking about technology revolving around the space and testing this in the field. And I read through the 12 steps that an officer goes through to evaluate someone, and a lot of it, to me, it seems like a lot of disposition can be brought into the situation on the officer's opinion, how he feels that day, if he had a bad day, and that could really tie into skewing what a case or police report would look like. Could you tell me a little bit more about how is this interpreted in a court setting? 'Cause I know you consult for a lot of people, and you're
Well,
getting called all the time to sit in on cases and give your opinion. Can you tell
sure.
me a little bit more
Well,
about that?
and indeed, just for balance, I do get called, and I've encouraged prosecutors to have me look at their cases. One of the requirements for the DRE officer is to have a toxicology present, so they get a sample of some type of body fluid, and it has to be the best sample is a blood sample. Sometimes they use urine samples, sometimes they have both. But the question I raise is they really don't have an understanding of what the chemicals that are detected are. They may indeed be the identity of the prescription drug that the subject has said that was prescribed, or it may be some other chemical that in fact is a metabolite of that substance. The presence of the metabolite is not an indication that it does anything, and it's certainly not an indication of impairment, especially one that is labeled as an inactive metabolite. But more importantly, and it goes to um, the evaluation, the levels of drugs that are tested for most patients on prescription drugs are not tested for the levels. The doctor makes the determination based on how the patient reacts. Patients themselves are not going to tolerate being zombies or being, like crazy cats with, either totally jittery or totally down. But when levels are tested, the numbers come back and they are pigeonholed into subtherapeutic, therapeutic, toxic, and even lethal. Therapeutic levels of the drug means and is expected to be that there is no impairment. But I've been involved in many cases where the officers and sometimes their experts on their side say, well, since they had therapeutic levels, they were impaired. Or since they had more than one drug, they had to be impaired. And that's not true. The proof of the impairment is in the clinician's evaluation of that patient. And it's very, very common for patients who are being treated with prescription drugs to be given more than one drug for that condition. And many people have many conditions for which they're treated. You have a chronic pain patient who have anxiety, so they're taking something like a Xanax, and they maybe have depression, so they're taking something like Prozac. They're not contraindicated, and that's what the physician is evaluating, is how the patient is doing, how they feel after they take it. It is not, by definition, impairment. Too many times I've seen police officers and even their clinician experts that they sometimes bring in when faced with testimony from an expert like myself, to say that, well, indeed, they had to be impaired. It's just not true, and that's what I bring to the case, is an evaluation of the toxicology, interview and examine the patient themselves. How do they appear? They're taking the same drugs today as they were when they were in that accident. They're not impaired now. They were not impaired then.
Yeah, and that all goes into the doctor's goal of prescribing something to have someone's life be more livable and tolerate their conditions that they have. So,
absolutely.
That was really insightful. Did you have anything else that you wanted to talk about on key takeaways from the conference and what you've seen?
I just add one more thing, and I heard it from an attorney today, and it's very poignant and relevant.
Who was it? Do you remember?
I think it was Elizabeth Landry from Orange County, California.
Oh, great.
And she said that, patients who are on chronic medication for pain and anxiety, if they were to stop taking their medication, they're probably an impaired driver just by the virtue of the fact that they're not taking the medicine.
And the withdrawals, I imagine, for each drug are vastly different.
They're definitely vastly different.
And that can cause impairment. B for the individual, because each person reacts so differently.
Absolutely.
Wow. Oh, that was excellent. Thank you kindly for spending time with us at the NACDL show. Dr. O'Donnell here, he's had a long, very impressive career. It's been a pleasure to spend some time with him on this topic, and very eye-opening to some of the objective things we can do to help improve this testing process and help arm officers with the tools they need to make objective decisions and help people out to move forward with drug recognition examinations in the field. That said, thank you kindly. We'll be doing a blog post on this. Please leave us your comments. Go to our website. We'll have it tagged on the video, and please contact us if you have any questions or wanted to start a conversation. My name's Danny. I work for Postali LLC. We're a marketing agency for attorneys, and we work with folks like Dr. O'Donnell all the time. Did you have anything else you wanted to say, or are we good?
I think we're good.
All
Thank
right,
you.
sir. Thank you kindly. Appreciate it.
Yeah.